Keisha Daniels had spent a decade on the medical surgical floors of St. Augustine Regional, but lately her unofficial title among the staff had become the data nurse. She was the one who noticed when a lab value drifted a hair beyond expected, who triangulated patient complaints with supply deliveries, who built quick spreadsheets in downtime that flagged things before they became crises. Her training in clinical informatics and infectious disease surveillance, self-pursued while working grueling nights, made her sensitive to noise that most people accepted as static. It was late October when she started seeing the whisper of a pattern. Three post-operative patients on different units presented with the same unusual constellation: low-grade fever, sudden abdominal cramping, and, disturbingly, a rapid spike in white blood cell count, followed by an unexplained transient hypoxia episode. None fit the normal post-op complication profiles. A surgical recovery nurse in orthopedics mentioned that the patients had all eaten from the newly introduced prepackaged fresh staff salads while recovering, and a respiratory tech noted minor coughing episodes that were dismissed as nervous by physicians. Keisha pulled the charts, mapped the rooms, noted overlapping staff, and added delivery times of the new salads and the cleaning logs of a portable imaging device used for routine follow-up scans. The cluster was small, but the vectors were converging. She went up the chain. Infection prevention, which was technically responsible, got a polite email copying her manager. Then she took it to Dr. Robert Ellis, the hospital's chief medical officer and de facto operations lead. White, polished, under pressure. In the conference room, she laid out her preliminary dashboard. 3 cases, temporal overlap, a common meal, and a possible breach in device sterilization linked to the decision to reduce overnight environmental services staffing. Ellis leaned back, fingers steepled. Keisha, I appreciate your vigilance, but we've got accreditation coming. Seasonal GI and mild post-op inflammation happen. We're not going to alarm the floor. Continue watching, document it. And if trends widen, we'll consider escalation. For now, keep it internal. No memos to the board or outside agencies. We can't afford a reputation hit. His tone was calm. The subtext was clear. Her concern was noise, not signal. Keisha left the meeting with more than frustration. The attempt to quiet her wasn't a blunt dismissal. It was a polished silencing wrapped in institutional risk management. She knew the language of "we'll see" and "keep watching" from years of being the one pointing out small fires before they chased her down the hallway. She didn't walk away. She pivoted. If formal escalation was blocked, she would build a case so tight, even the bureaucracy couldn't ignore it. Keisha went back to her workstation and began the real work. She set up a private, secure spreadsheet tracker, patient demographics, exact times of salad consumption, staff interactions, cleaning logs of the portable imaging unit, and a timeline of staffing changes in environmental services and food prep areas. She tapped into the electronic health record to pull vitals trends, flagged the subtle oxygen desaturations that preceded overt symptoms, and cross-referenced staff schedules, noting that the night shift of a particular tech had been operating the imaging device outside of the normal protocol. Shortcuts adopted after cuts in cleaning personnel had left him overburdened. She enlisted help quietly. Dr. Tyler Grant, a junior infectious disease fellow, white, earnest, and new enough to still believe systems could change if presented with evidence, had once seen Keisha's dashboards during a quality improvement huddle and been impressed. She approached him with the data and the story, framing it clinically rather than emotionally. I'm seeing a small cluster with a likely common source. If we don't cohort and intervene early, it's going to seed. I need an extra set of eyes for pathogen identification and some institutional cover. Tyler didn't hesitate. He ran parallel cultures on stool samples, requested PCR panels that weren't standard for the presentation, and began sequencing an isolate that looked off. A gram-negative bacillus with early signs of multi-drug resistance that shouldn't have been in the general population yet. Meanwhile, Keisha walked the floor. She talked to the environmental services team undercover, asking how often the device was cleaned, what supplies were available, and hearing defensive but telling comments like, "We've had to stretch the shift. The disinfectant's been on back order." so we're doing wipe downs instead of full cycle protocols. She quietly recorded testimonies with permission, time-stamped photos of improperly stored cleaning supplies, and logged instances where staff had reused single-use components because replacements hadn't arrived. Her spreadsheet began to look less like an anecdotal concern and more like a predictive model. If this vector wasn't interrupted, the infection would jump from isolated cases to clusters of severe sepsis and respiratory compromise. With Tyler's backing, she compiled a polished but quiet briefing, charts, early isolate sequencing, suggesting a new mutation facilitating environmental persistence, and a risk projection model showing the exponential spread potential if no intervention occurred. She prepared two versions, one labeled Escalation for Internal Review and another packaged to send to the local public health department. She didn't want to go around hospital leadership, but she also was preparing for the moment the trend expanded beyond the threshold Ellis had set. The day the fourth patient's status turned critical, Keisha requested another meeting with Dr. Ellis. This time, she didn't present hypotheses. She brought near certainties. The patient's culture grew the same unusual gram-negative organism. Sequencing confirmed the mutation Tyler had flagged, and her predictive model projected 3 more cases in the next 48 hours, unless source control happened. She laid it out plainly. This is not a seasonal blip. This is an emerging outbreak seeded by cross-contamination from both contaminated food and improper device sterilization. We need immediate cohorting of affected floors, suspension of the salad deliveries, and a full procedural halt on the imaging device until sterilization protocols are audited. Ellis's face tightened. He flipped open his planner, sighed, and said, Keisha, I'm hearing the word outbreak, but what I'm seeing is alarm escalation. Pull back the language. If we declare an outbreak prematurely, we will have floors closed, elective surgeries deferred, and media calling. Those outcomes have financial and reputational costs. You're a valuable nurse, but I need you to understand how this sounds to the board. Fear-mongering. Keep the cases under observation. Tyler, too, is enthusiastic, but fellows see patterns that don't always hold. He paused, then added, and Keisha, try to moderate how you present to the staff. Some people feel like they're being blamed. If this doesn't widen, I might have to put that concern on your performance notes. I need buy-in to lead, not tension. It was explicit now. The subtle layer of too sensitive slipped into outright threat. Keisha felt the old reflex, to cave, to label it watchful waiting. But she couldn't. Lives were potentially on the line. She requested the hospital's infection control committee meeting be moved up. The response she received was a delayed, "We'll see about availability." She emailed the local public health liaison with a redacted version of her findings, noting she was seeking guidance on whether to elevate these emerging trends given internal constraints. She CC'd no one else. The reply came back within hours. Please provide full details. If this is an outbreak, under statute we can provide epidemiologic support. We need timely information. That night, a nurse from the general medicine floor, white, exhausted, and quietly grateful for Keisha's past help, told her in a hallway whisper, "You're doing the right thing. The patients keep getting sicker faster. Don't let them shut you down." Keisha nodded, offering a tight smile, and pushed her next dataset update to Tyler. The projected cases were now 5, with a spike in staff having mild symptoms, something that could tip into broader nosocomial spread. The 5th and 6th patients landed in the ICU within 48 hours, both with septic presentations, one with early acute respiratory failure. News traveled across the nursing stations. We've got another one like that. And the murmurs shifted to worry. The local public health team, now looped in by their liaison, sent 2 epidemiologists to partner with Tyler and Keisha. Their initial field sampling confirmed the strain was not only present in patient cultures, but had been isolated from condensation in the staff food prep area and from swabs of the imaging device's handle and internal compartments, areas marked cleaned in logs, but clearly compromised. Keisha put her plan into action. Using her model, she convinced the acting unit manager, a white nurse with a history of quietly advocating for frontline perspectives, to cohort the affected patients, restrict admissions to the implicated post-op recovery wing, and initiate immediate staff screening for subclinical signs, under the emergency authority granted by the mounting clinical severity. She organized a rapid education huddle, how to don enhanced PPE, real-time updates on what to watch for, and a clear, if you feel off, report immediately protocol that bypassed the usual chain to prevent further delay. Tyler used his credibility to push the lab to prioritize rapid diagnostics. The public health team began contact tracing. Word got to the hospital's executive team. Ellis was flooded with pages. The floor looked different. Tape delineated zones. The food service was pulling the prepackaged salads, and a temporary double clean process was instituted on the imaging device. Ellis called an emergency meeting and, in front of other administrators, asked Keisha to brief. She did. No theatricality, just facts, projections, and a blunt assessment of potential mortality if the strain breached the ICU into the general population. The pressure at that point had shifted. The same system that had tried to quiet her now leaned on her model to justify drastic containment measures. She insisted on transparency to clinical staff to ensure compliance. Half measures would cost lives. The next 72 hours were a flurry. The combination of early cohorting, immediate removal of contaminated sources, aggressive antibiotic stewardship tailored to the susceptibility profile, and the temporary halting of elective surgeries in nearby wings prevented what the epidemiologists had predicted would be a full-blown hospital-wide outbreak. 2 patients deteriorated further, requiring prolonged ICU stays. But thanks to rapid intervention, none succumbed. The chain had been broken. The Public Health Department helped sequence and publish initial findings, with Keisha's dataset cited as the crucial early warning system that allowed targeted intervention before the reproduction number could climb. The backlash was immediate and internal. News of the near outbreak leaked to a regional health reporter, who called the hospital for comment. The institution, needing to control the narrative, held a press briefing. Dr. Ellis, under pressure, publicly framed the situation as a swift, coordinated response to an atypical cluster, highlighting Tyler's Fellow's infectious disease expertise and the public health partnership. Keisha's name was omitted initially in the prepared remarks. The reporter, however, had already spoken off the record to several nurses and to Tyler, who quietly said, "The reason we didn't have a deadly outbreak was because the one person who spotted the anomaly kept pushing even when the tone upstairs was to hold off." The reporter dug. Her article, when it ran, included a sidebar about institutional hesitation and a quoted paragraph from the public health liaison acknowledging that early escalation hinges on frontline voices. The hole in the official narrative opened wider when someone anonymously forwarded the earlier internal email where Ellis had advised, "Keep it internal, moderate language." The hospital's ethics committee, pressured by public scrutiny and the potential legal fallout, launched an immediate internal review not only of the infection control response, but of the decision-making chain. Keisha was pulled into meetings, some as a matter-of-fact finding, others awkwardly framed as, "Help us understand your communication so we can streamline future alerts." And she held her ground. She demanded that the review not be about individuals alone, but about why the system had elevated inertia over early signal. After the immediate danger had receded, the hospital convened a formal post-mortem. The Infection Control Committee, the public health team, staff representatives, and the executive leadership sat around the polished conference table. The first draft of the after-action report had a chapter written by Keisha. The timeline, the barriers, the data that predicted the exponential trajectory, and the mitigation steps that flattened the curve. Her section also included a scathing analysis of the institutional culture that had prioritized optics over early warning. How quieting language had almost deferred the only window they had. Tyler, sitting beside her, added the clinical perspective. The epidemiologists presented the statistical model showing the counterfactual. Without early cohorting, the outbreak would have likely infected dozens and cost lives, given the reproduction characteristics of the strain and the hospital's patient throughput. Dr. Ellis, facing the panel, made a rare public admission. "I erred," he said, voice measured but real. He acknowledged that his initial instructions had delayed formal escalation and that the framing of her concern had reflected a bias toward minimizing disruptions rather than interrogating the signal. He didn't frame it as a personal failing only. He proposed structural change, creation of a permanent frontline surveillance and empowerment committee, a revised escalation protocol that allowed nurses and allied staff to trigger an automatic intermediate review when certain patterns met predefined thresholds, and mandatory implicit bias and communication training for leadership. Keisha was offered the co-chair position of that new committee with a formal title, Clinical Surveillance Liaison, giving her the authority to bypass traditional chains when her early warning metrics triggered. The hospital also overhauled its whistleblower protections, explicitly referencing the need to shield those who raised safety concerns from reputational or performance retaliation. Ellis's admission didn't absolve him fully. He was required to participate in a mentoring program about leadership humility and was placed on a 6-month performance watch regarding inclusive decision-making. The hospital instituted a transparent public dashboard for infection trends, curated in partnership with frontline nurses to rebuild trust. Keisha declined a standard Employee of the Month plaque. Instead, she proposed a yearly Early Signal Award to recognize any staff member whose vigilance prevented harm. The board approved it. She also negotiated funding for a peer mentorship pipeline focused on supporting Black nurses in acquiring informatics and advocacy skills. She had seen how easy it was to be dismissed and wanted others to have tools earlier. A year later, St. Augustine Regional was cited in national healthcare safety journals as a case study for an effective frontline-driven early detection system. Keisha's data pipeline had been standardized into a toolkit rolled out across the network's sister hospitals. She and Tyler co-authored a training module, Frontline Signals, Turning Observation into Action, now part of orientation for new clinical staff. The hospital created a scholarship in her name for underrepresented nursing students pursuing informatics. Younger Black nurses, once hesitant to raise concerns, now publicly referenced her example in staff meetings. If Keisha saw it, I'm saying it too. Dr. Ellis and Keisha's working relationship evolved from tension to a wary, functional partnership. He occasionally defers to her early in meetings when trends emerge, and she holds him accountable when he lapses into old hierarchical reflexes. The surveillance committee she co-chairs includes rotating nurses, a public health liaison, and a patient family representative, keeping the lens broad. The hospital's culture shifted in small pockets. Staff no longer whisper, "Is she overreacting?" when a Black nurse raises a red flag. Instead, they ask, "What data can we collect to support and test it?" The public dashboard transparency kept community trust high. When a new variant of a common virus emerged, the same mechanisms mobilized before caseloads spiked. At a community health summit, Keisha was invited to speak. She didn't talk about herself. She spoke about systems, about how a quiet email, keep it internal, could have become a headline for tragedy if not for persistence, and about the difference between being seen and being heard. A young nursing student approached her afterward, eyes shining. "I want to do what you do," she said. Keisha handed her a small notebook, the same one she'd used to sketch her early dashboards. "Start listening," she replied. "Then learn how to translate what you hear so the people above can't ignore it. Don't wait for permission to care." In the hospital's hallway, a bronze plaque now hangs near the infection control office, in recognition of the vigilance that saw beyond silence and the courage to act. Keisha Daniels, Clinical Surveillance Liaison. Underneath, in smaller type, she insisted on it, reads, "For those who speak first and save many." The outbreak that could have carved itself into regional tragedy instead became a blueprint. And in a quiet room on a Thursday afternoon, she sat with a new cohort of nurses, teaching them how to build their own dashboards, each one a small armor against being silenced.